Voilà, et avant de lancer cette première table,
Before we launch this first roundtable, there are so many people writing into us, so I would like to thank you, those who were writing in from Germany, Seydou, who's watching us from and Fada Ngourma, from the east of Burkina Faso. Have a lot of people writing to us from Mali, messages from Bangladesh, from India, from Togo, from Paris. We have a hello from Mongolia, from the remote dermatology service department in Mongolia. And a hi from the mental health team platform in Benin. They're all interested in AI and the unrolling of AI in countries of the South. And this is what we will now see in this round table, where we have Dr. Cikū Mathenge, who is an ophthalmologist. Please do come up. He's an ophthalmologist.
Originaire du Kenya.
She's from Kenya and works today in the Institute of Ophthalmology of Rwanda. And you can tell us how you're developing the diagnostics with AI in Rwanda. Thank you very much for having traveled to be with us here today. Peggy, who's a product manager with Google Health and who's traveled here from San Francisco. And we can give her a round of applause. She's going to join us up here. Peggy, where are you? If you could please join us up here. And then we will see with you how Google contributes to the development of health tools and with artificial intelligence in the field of dermatology, among others. And remotely, we hope that things will work. From Switzerland, we have Professor Alexander Navarini, who is in charge of the dermatology department in the University Hospital of Basel. And so it's not Professor Alexander Navarini who's here, but it's Professor Paisan, who is also with us remotely, a professor of ophthalmology who's working in the hospital of Bangkok. Good morning, Professor. Can you hear us from Bangkok?
Yes, I can hear you.
Merci.
Can you hear me?
Yes, that's perfect. Merci beaucoup d'être avec nous aujourd'hui. Et c'est vers vous que je me tourne tout d'abord, puisque dans un pays comme la Thaïlande...
So I'm turning to you, because in countries such as Thailand, there are 7 million diabetic people. That's practically 10% of the Thai population, with the risk of these people of developing what we call diabetic retinopathy. And that's a disease that can be properly treated if we catch it in time. However, if we catch it too late, people can become blind. In the 90s, for example, in Thailand, 1/3 of the blind population was blind due to this disease. That gives you an idea of the scale. And therefore, the authorities decided to train nurses and healthcare workers to really go out and meet the populations, in particular rural populations, just to, do some ophthalmological examinations. Professor Paisan, you are equipped with AI machines, and you're equipping the people to go out into the field for these diagnostics. Where do you stand in terms of the unrolling of these tools, and what percentage of the population are you targeting with regard to the screening of your population?
We target the patients with diabetes. Can I share my screen? I think this may give you a little bit of overview of what we are doing in Thailand. Can you see my screen now?
Oui, c'est parfait.
So this is the picture of global impact of diabetic retinopathy. Is the leading cause of blindness in the working population in the world, and the number of people with diabetes, especially diabetic retinopathy, is growing, and especially the number of patients with vision-threatening retinopathy. As you can see, it may increase from around 40 million people to be 56 million people in 2030. And the way of screening diabetic retinopathy is to detect cases for referral to ophthalmologists. There's a recommendation by the American Diabetes Association and the International Council of Ophthalmology to screen patients with diabetes at least once a year. It means patients with diabetes should have eye examination once a year. And because we don't have enough ophthalmologists to do the screening, to do the examination, so we use the photos. As you can see, the upper part is the picture of retina without retinopathy, and the lower part is the picture diabetic retinopathy. As you can see, the difference is quite obvious. So we are able to take the cameras to screen diabetic retinopathy, to take pictures of retina of patients with diabetes in communities. In the past, we trained in the middle upper photo. You can see we train personnel who's not doctor to be able to read these images to detect retinopathy, to refer for treatment at tertiary care centers. This is what we are doing in the past, but currently we are in the kind of transition phase. Instead of training the personnel, we try to use AI. You can see the sensitivity for the trained personnel is 75%, but for AI it's 95%. So we want to detect cases for referral for treatment, timely treatment, using AI now at the moment. This is what we are doing in Thailand.
Professor, vous nous montrez effectivement.
Professor, indeed, you're showing how you're unrolling AI massively in direction of the concerned population. You also compared the reliability of an AI diagnosis as compared to a diagnosis with a human eye. You've done some studies on this subject. What are the results of these studies, and what are your feelings on the matter?
Oh yeah, this is a good question. So we conduct a study we call retrospective studies. We use the existing images, like around 12,000 images, and we used 3 retinal specialists, one from the US, one from India, and one from Thailand, to read the images as the truth. And we add some images, and we use AI to read same set of images, and we found that, as I showed in the slide, we found that the accuracy of AI is like 95%, and the accuracy of the overtrained graders is only like 75%. That's a retrospective study. Then we move on, because the result is quite good. Then we move on to conduct a real-time prospective study. It means we didn't use the existing images, but we conduct a real-time analysis. It means the patients who come to the clinic, we ask them to sign consent, allowing to use AI for diagnosis. And we ask the nurse to take the real pictures, and the nurses will upload the real pictures into the cloud. AI is in the cloud. And the cloud is going to analyze the images and then send the result back to the screening site. And AI is going to delete the system in the cloud, is going to delete all those images, send only result to the nurses at the screening site. And the nurses at the screening site is going to give the results to patient right away. So this is going to take like less than 2 minutes. And this is we call like a prospective study, real-time study. So we found that in the real-time study, the sensitivity of AI may be a little bit decreased from like 95% to be like 91%. But specificity of the AI system is still the same. It's about 95% comparing to the retrospective study. So now, during the last fiscal year, from October last year until like September this year, we're able to have more than 20,000 patients already. And I think the accuracy is about the same. We're able to detect referral cases of 90% accuracy. Thank you.
Merci, Professor. Reste avec
Thank you, Professor. Do stay with us. These figures are very impressive, these AI diagnosis figures. So I turn to Dr. Cikū Mathenge, because you have a similar project that you're leading in Rwanda, and you have the first machine that will soon be with you. We're not going to come back over the technology, because the previous speaker has explained the advantages of these technology, and you're going to be using the same technology. But I would like to talk to you about the way in which AI leads us to rethink the healthcare for the patient. And it's very impressive, because when we prepared this roundtable, you said, well, this AI equipment, I don't want that in my clinic. I'm not the main person who should be receiving these machines. Can you explain why?
Done with our project in Rwanda is not about it's not about testing the accuracy, but actually using the AI in the field directly. And for me, it was important to do this because we have very few ophthalmologists in Rwanda, meaning we have almost no retina specialists. And previously I used to go to a clinic and sit there and screen people with diabetes and then send them for care. I could only do this like 3 times a year because the rest of the year I'm doing my normal work. So I wanted a solution that allows me to do only what I can do, which is treat the patients. And so that's why we put an AI solution called CyberSight AI into these diabetes clinics and trained non-clinicians how to use the application. And now I only receive patients who need to see me. We were a bit worried about the acceptance by patients. And when we started the project, we used to ask every patient and say, you can get your diagnosis done by humans or you can get it done by artificial intelligence. And the difference will be how quickly you get the result. And 99% of the patients wanted to get an instant result.
C'est extrêmement important.
This is, what you're saying is really important because very often the medical staff, the main criticism says that, the patients won't trust in an AI diagnosis necessarily. And you're saying that yet they do trust it.
Exactly, and I was worried. In Kinyarwanda, the local language, a computer is called the thing that never gets confused. So maybe that's why they had so much confidence in AI. But it was an important question for us because introduction of telehealth in Africa sometimes is limited by people's acceptance of being diagnosed by machines. But for my patients, what was important was getting that report as quickly as possible because a lot of our systems, that's where they fail. You go for an X-ray and you don't know what it said for several days. So I think the ability of AI to generate these instant reports was very important. But also what I was looking at is there's no need of screening people if when you tell them they have disease, they don't go for care. So my study was, so after they improve, they are going to the doctor. And what we found is that giving them an instant report improved them going to the eye doctor by 30%. And for my patients, it was because it saves them another journey. So they come from far and on the same day, they will see their diabetes doctor. They can actually go to the eye doctor the same day. It saves them the transportation. It saves them, losing another day when they could be working wherever they work. So that was really interesting for me.
C'est extrêmement passionnant.
I wanted to say that when you're dealing with the patient, you're saying that nowadays patients must go and see an ophthalmologist and then another diabetic specialist and then another place to have treatment or go and see their GP and then go and get the medicine. It's a lot of travel. And you say, well, a lot of patients, but it's not specific to the South. It's also true in the North. A lot of people actually give up taking care of themselves because it's too difficult for them and it's too split up. So how can this automatic diagnosis facilitate the treatment of the patient?
Thank you. This has been really important for us because it's hard for people to find time and money to go and see doctors. So for diabetes patients, their care can be very disjointed. They go and see the diabetes doctor who tests their sugar, maybe their blood pressure. Then they have to see the heart doctor, the kidney doctor, the eye doctor. It takes a lot of time in their lives. So AI allows us to put the eye check exactly in the same room where they get their diabetes check. And again, when we asked our patients, we said, so the addition of this extra test, do you feel it's wasting your time? You're taking too much time? And they were all said it's better to take time today than for me to be told go to see another doctor. So that's what we found.
Extrêmement intéressant, de manière disruptive.
Very interesting. It's a disruptive manner of establishing a diagnosis and to revisiting the patient pathway. So a lot of questions on AI coming up here. We talked a lot in the introduction about the notion of databases. How did you train these machines to analyze and diagnose with such accuracy if you have a diabetic retinopathy, for example, or other eye diseases? Did you naturally find databases? Did you have local databases, or did you need to go and retrieve databases from the north? How did you go about it?
So I didn't develop the AI platform. I was assessing its use. But what I found interesting with CyberSight AI is that I had access to the machine engineers who do this stuff. So at first, when we started working with it, we did have problems. I felt it was not interpreting my patient's retinas the way I thought it should. And the first step was, to feed this engineer with as many retinas from my patients that I had access to. I'm lucky because I had done a large study looking at retinal diseases in Africa, so I have a huge curated database of retinal images, and I could give them to these engineers and then make it more accurate. I was not happy with the way, for example, it was looking at the optic nerve. Maybe because of the excessive pigmentation we have, I felt this is not correct. And what I really liked about CyberSight AI is that access to the engineers so that I could say, I don't think this is right. And they were willing to work with me until we got a product that was accurate. But I do think we need to do that. We need to manage data from different populations and not just give them to people, but participate in how that data set is used. And I think that's what's lacking. A lot of people now want to collect data from Africa, but that's it. After they collect it, we don't know what happens. But I was privileged to be able to participate in how this was being used to improve the model.
Well, in what you're saying, there's a very important notion of the quality of data that is analyzed by AI, and in particular the local or regional nature of this data. And you can't exchange everything. You might think that a human eye is a human eye, but we need local databases in order to analyze human eyes from your country. In terms of the business model of these solutions, there is a cost for the patient, cost for the health system. When there is a structured health system, how did you work out this question of the business model? How can you financially guarantee the development of these solutions?
Yeah, that's a really important question. And I haven't answered it because I was lucky to have access to CyberSight AI for free. But it's unrealistic to think that these AI platforms will continue being free. So we do need to cost them and see what is realistic for populations like mine to be able to access. I think we need to start developing those economic models and presenting them to our governments and our insurance systems. But I imagine that it can never be more expensive than my time as a retina specialist seeing the patient. So that's the argument I would give to government, that if I have to look at this image and grade it, my time is very expensive. AI will never be that expensive. Also, if I get somebody with disease early, it probably costs like 20 euros to treat that problem. If they come later, and I need to give injections, it's about 1,000 euros. If they need surgery, it's like 3,000 to 5,000 euros. So we have convincing evidence that using AI to detect disease early will save money, and insurance companies and government health systems should be able to appreciate that.
Mais aujourd'hui, de manière concrète,
but today, concretely, who is paying for these solutions? Do the patients pay 100%? Does the clinic pay part of it because you're saving time on the examinations? Does the government participate to the cost of examinations or to the construction of algorithms?
So currently, patients just pay as if it's a consultation. We haven't costed what is the cost of the imaging. Unfortunately, AI works with images, and the gadgets we use to image are also expensive. So that's an additional cost even before you reach the cost of AI. I think that's a gap that we need to discuss and understand. But because there's been such little deployment of AI in our region, we haven't yet got models that allow us to cost and then determine who will pay.
Beaucoup de réactions sur le chat.
So we have a lot of comments here on the chat. A lot of people who are reacting to say that the detection of a diabetic retinopathy is a very impressive project. And this question that you have just answered as to whether these projects will be accessible to the less fortunate population. So I'm going to turn to you, Professor Paisan, who is still with us from Bangkok. Professor, are you still with us? A quick question for you, because there is the question of the cost for developing these solutions. You have chosen to work with Google to develop your solution, your algorithm. Why did you choose to turn to an American giant?
Well, this is a good question. We collaborate with them because we saw their paper. We saw their published paper. And we have our trained personnel who have accuracy around like 80%. And we're happy, but their accuracy is better. That's why we collaborate with them. And during the collaboration, we do a lot of study together. And there's no cost of their AI. And currently, the screening of diabetic retinopathy in Thailand is taken care of by the government, for the people of Thailand, for getting a screening. And since we are conducting like study together, during the study, there's no cost of AI as well. So actually, there are no cost of AI for Thailand yet. But after this phase, I think after the study, we will take a look at it. I think the cost for Thailand will be very reasonable because it's going to be taken care by the government, part of the usual coverage insurance scheme as well.
Merci, professeur, pour cette réponse.
Thank you, Professor, for this answer. And we're very lucky to have with us today somebody from Google. Thank you for being with us, Peggy Bui. So a very simple question. We can see the different agreements you have with Thailand and other countries to develop Google solutions. What is Google's interest today in the medical sector? For YouTube, you can understand because there's a big advertising market that they can gain from this. For driverless cars that are officially authorized in San Francisco, we understand the financial interest of Google going to this. What is your interest in the medical field?
Well, first off, thank you so much for inviting me here. I'm so honored to be here and listen to all the great work that's being done globally. I think when people hear Google, naturally people think about, well, this is a big corporation. There must be some sort of other angle here. But the reality is that all corporations are made up of people, of individuals, people like people in this room. And health is such a universal topic with a lot of personal appeal. A lot of people here at our organization, organizations everywhere have a personal health story, a family member, someone else who's been affected. And so for us, a lot of the motivation for pursuing AI and health has been rooted in recognizing this huge global need. As Dr. Paisan and others have already highlighted. So, at Google, certainly for many years now, we've been good at using AI to classify objects, to localize objects, to summarize entire scenes, right? And so several years ago, a group of very passionate employees got together and said, hey, look, if we can classify, what type of flower this is, if we can localize, oh, here's the bus in this map scene, if we can even say, oh, this is a group of rugby players enjoying a lunch break, right? Can we take these same AI capabilities and be able to apply that to something that will meaningfully impact a lot of people's lives? Like classifying, how severe someone's diabetic retinopathy is, or localizing in this biopsy, this is where we see the tumor, or this is where we see the abnormality. or summarizing a radiograph, or actually more recently even a smartphone picture of someone's skin and saying, this is what this could be, this is what this looks like, this is a fracture in the metatarsal or something. And so it's really about leveraging a lot of high quality engineering talent and feeling like we're putting it to good use in the world.
Et on sait bien sûr que les talents d'ingénieurs sont.
Yes, the engineering talents are tremendous in Google, and you have such a capacity for research in Google. And Professor Paisan, recalled this. They have capacities and skills that are there. You have agreements with Thailand. You have agreements with other countries. So, how concretely do you intervene to support the countries who turn to you for research around artificial intelligence?
Yeah, that's a great question. We see in these partnerships that the other countries are true partners. And to be quite honest, the program in Thailand would not have been so successful had the partners not been so genuinely interested in making this possible. And you've already heard from Dr. Cikū that she herself contributed with trying to make the AI better to make it work for her local population, right? So in these partnerships, certainly we bring a lot of engineering expertise, and we help guide in terms of teaching the local community about the capabilities and limitations of the AI, but we really look to the local communities to understand what is that salient problem that you're trying to solve. How can we best use these technologies to help you with that problem? What are the gaps that you've identified so that we can make the project better for everyone? So we don't go into these collaborations assuming that these solutions will work perfectly out of the box. Conversely, we actually assume the opposite, that it's not going to work perfectly, and we look to the partners to help us understand, okay, in what scenarios is it most appropriate? How does this fit into your workflows? Because we don't want to disrupt something that is already working well.
Je profite d'avoir quelqu'un quand même de Cikū.
So I'm going to take advantage of having somebody from Google with us who is at once a doctor and who works in the world of engineers, because we have so many questions from all different areas about AI. The question of databases keeps coming back there on the table with artificial intelligence, and we saw how with Dr. Cikū how important it is. One of the paradoxes is that a lot of researchers with AI work with academic databases that come from hospitals, and you say it's good, but it's not necessarily always the best solution. Why?
Yes, that's definitely an interesting topic, and so a lot of times when we leverage data to train the AI models, these data can come from hospitals, clinics, academic centers, where it's actually a trained professional who's capturing the image. So either it's a doctor, it's a nurse, it's someone who's trained to capture the image nearly perfectly or to the best of their ability. But in the real world, we have everyday people who are just quickly snapping a picture. This is especially true if it's not a medical grade image. So for example, if it's not a fundoscopic image or a chest x-ray or something like that, where it's just someone with their camera, we see a lot more variance in the real world in terms of how pristine the image is. So AI, as Aziz mentioned in his talk earlier, it captures all the inherent biases of the data that it's trained on. And so one of our very early realizations was we had this data set come in from an academic center. It was a beautiful set of data, very high quality, high resolution images. And we realized that sometimes when doctors are really worried that this could be cancer, they often put a ruler in the image to measure the size of a lesion or to measure whether or not something is growing in severity. And the AI tends to pick up on whether or not a ruler is in the picture as a proxy for, does this person have cancer, right? And so we have to recognize that in the real world, the range of pictures that people submit is much greater in diversity than what we might get in an academic center, where there's a totally different purpose and intent for that original image.
Et ce que vous nous dites, et merci de le préciser.
So thank you for clarifying this. It's extremely important in terms of databases. There is, of course, the local, regional aspect where we need to come close to the population, but we also need databases that collect together the things that the nurses and people in the field and operators which are degraded quality, which is as compared to hospital. So that's something that's very important for the North and the South. Among the other paradoxes, let's talk technical matters. One of the paradoxes, which is very complicated, is the fact that AI will find solutions and diagnosis that work. We're not always able to explain why and how they find it. That is a true conundrum. And a few years ago in the Nice hospital, they compared patient cohorts with cancer 4 years before, 4 years after. We gave the case studies to AI, and the AI managed to identify who was developing cancer, but we couldn't explain why. So we look at things through different lenses in Europe and the United States. You say Europe often asks us to prove and to explain how we do this. The United States would tend to say, well, look, it works. Why should we bother trying to prove things? Could you explain, therefore, how you can manage your relationship with Europe?
Okay, that's a very challenging question.
Indeed.
Indeed. I will say Europe tends to be much more cautious from a regulatory standpoint when it comes to a lot of these new technologies. And with AI, as many others have already recounted, we can't always explain exactly how it works. Certainly we do try. So we have some projects where we look at things, what we call saliency maps, where we can say, think of it as like a heat map almost, where certain parts of the image we can light up and highlight and say, this is what we know that the AI is focusing on, so that at least if a human is looking at it, they have some understanding of, oh, this is why the AI thinks this, this, and this. We're working on some other projects where we're trying to even summarize that in text and say, okay, this is the pieces that the AI has weighted with what's important for its ultimate recommendation. But at the end of the day, there's always going to be cases out there where we don't know why the AI thinks it is this way or that way. And so it comes down to a philosophical question of, what would you rather, right? Would you rather have something that's very highly accurate, but you can't always explain why? Or the status quo, which we have seen in many studies that the AI does perform better than like an aggregate group of doctors, right? Because it is taking that input, that collective intelligence from all the millions and millions of data points that it's seen. So to your question, I don't know that I can fully answer it, because I feel like we would need someone from the European regulatory bodies here to kind of address how they think about this. But I do think it's an important question to solve, because already we see with these new technologies with large language models, a lot of AI is being deployed worldwide, where Europe is kind of being held back as the exception region. And so it may very well be that a lot of these new technologies either bypass or come to Europe late as a result. And I'm not really sure what the right answer to that is.
Dr. Mathenge, vous souhaitiez compléter.
Yeah, it's interesting listening to that question, because we are neither in the US level or the European level, and it's important for us because the deployment of AI right now in my region is pretty much unregulated, and we don't have the policies and frameworks to guide how we continue. But I think that we need to choose a ground that is useful so that it's not too restrictive or stifle innovation and what we can do with AI. So I hope that as African governments start developing these policy frameworks, and I think that's one area of support that Africa needs. It's in developing the appropriate frameworks, that we kind of reach that good balance where we don't block things, but we also don't just allow unregulated use of our data or our interpretation of our data.
Merci beaucoup de cette contribution. Effectivement, ce sera aussi l'une des grandes questions de la table ronde.
Thank you for this contribution. Yes, this will be a topic of the roundtable this afternoon. I have the impression that every time we talk about AI, we open a window, then another one behind that, and it's endless. Among the last paradoxes that I wish to highlight in this roundtable, there is the fact that for AI, you say in Google, we can launch a project in a certain region of the world, for example, in the United States, around AI, and it doesn't work. And then we realize that, to the contrary, the same AI project works elsewhere in the world. So could you give us some concrete examples of this? Because it seems crazy.
Yeah, I guess I would clarify and say that it's not that it doesn't work in the US. It's more that so sometimes when we train certain models, we use data that mostly comes from the United States. And so our expectation is that these models would work well in the United States, and in other regions it might not work so well because there are regional differences, and we expect what we call a distribution shift when we deploy these models to other regions. And yet, surprisingly, what we've learned is that sometimes these models actually end up working even better in some other regions, which was the opposite of what we were kind of taught to believe, right? And so we don't have a clear explanation for this quite yet, but I think most people recognize that the United States is a region that has immigrants from countries all over the world, and so that may play a role in the generalizability of some of our models.
Extrêmement fascinant. Dr. Mathenge.
I don't have case studies, but I can talk from some of my experiences. So because the AI we use in ophthalmology depends so much on imaging, as Peggy said, the quality of the image you get determines how well your model will perform. So even with the CyberSight AI that I use, when different cameras are used to get the images, then the performance is different. And one of the problems that we struggle with is that there's a trend to want to develop a lot of mobile, portable solutions because people feel like that's more appropriate for Africa or for the poor countries. And I always resist that because my solution depends on a good image. And if a big camera is what gives me a good image, that's what I need. And let me figure out how to move around a big camera. And it's never been a problem. But kind of trying to convince me that a portable handheld camera will be the solution, that causes problem. The other scenario is that a lot of machines use normative data. And we don't talk about normative data. But I remember in a project I was doing looking at glaucoma, I used the gold standard machine that we use to analyze what we call a visual field. And I just felt that the interpretations were not, they were not tallying with what I was seeing in the patient. And I remember publishing this manuscript saying that I believe the problem is the normative data in this machine. Because it's not based on an African population and what the visual field in an African looks like. And that paper has never been published because I guess it was a bit too controversial. But I wonder, I mean, we get these machines now in existence. How big is the normative data? How diverse is it? And my fear is that some of the things that we're telling AI to do are also based on what those machines with normative data itself that's not representative is interpreting as normal or abnormal. So I think it starts from there.
Passionnant, hein, tout ce monde autour de l'IA.
It's so interesting, the question of data, of norms, of the specificity of population and related data, and also the question of the quality of images that we were able to use, and its subsequent interpretation by AI. And to add to this reflection, I suggest we head off for Basel, where we have the Professor Navarini, who is in charge of the Dermatology department in the University Hospital of Basel. Professor,
vous nous entendez
I don't know if you can hear us properly. I can see you on the... Can you hear us properly?
Yes, hello.
Bonjour. Alors, je sais que vous êtes francophone. Si vous avez le choix.
Yes, I know that you're French speaking, so please do speak in French.
Qu'on explore un autre projet.
So we would like to explore another project with you, this time in dermatology in Madagascar.
Moi, je parle français parce que comme ça, la tradition, peut-être, c'est plus audible. C'est difficile entre l'anglais et le français. J'ai pas entendu l'anglais quelquefois. Okay. Super. Merci pour l'invitation. C'est un grand honneur.
Écoutez, on va pouvoir le faire en français si vous le souhaitez. On a un service de traduction de toute façon qui est automatique derrière. Oui, je reposais ma question. Je voulais avec vous qu'on rentre dans un projet de dermatologie que vous menez à Madagascar avec de l'intelligence artificielle pour aller détecter des pathologies en dermatologie, peut-être plus sur les enfants dans un premier temps. Est-ce que vous pouvez nous expliquer ce projet que vous menez?
Oui, très brièvement. La prévalence de dermatose en Afrique, c'est très élevé, spécialement dans les enfants. On voit beaucoup d'eczéma impetigo, c'est une maladie bactérienne. Alors les champignons, Tinea capitis, scabies, c'est très fréquent et très souvent les medical officers qui sont en charge de détecter, faire le diagnose et traiter ces patients, ils n'arrivent pas à faire le diagnose, même que les médicaments sont là et peuvent être achetés dans plusieurs des parts de l'Afrique qui est challengé. Alors, je ne parle pas de toute l'Afrique, c'est juste pour ce slide, on a généralisé un peu, mais évidemment, il y a beaucoup de différentes régions en Afrique. Et à Basel, en Suisse, oui.
Non, je disais là sur le projet sur Madagascar, justement, vous nous dites, vous avez le souhait d'aller détecter 4 maladies, plus précisément.
Exact, c'est 4 maladies.
Yes, these 4 diseases also.
4 maladies.
4 diseases which
très différents. Alors c'est facile.
Are very different.
Pour un AI de faire la différence.
And it's very easy for an AI to establish the diagnosis.
Ce que je montre ici, que c'est la dermatologie.
What I'm showing you here is dermatology.
Alors,
normalement, on fait la dermatologie avec les docteurs humains.
Alors, je résume, parce qu'on a des tout petits.
So we have some sound problems.
4 maladies, eczéma.
So I was saying we have 4 diseases: eczema, impetigo, tinea, and scabies. And you are currently developing a project so that social workers and doctors working remotely can take a photo with their smartphone, send it to via WhatsApp to a department and see if AI can detect these different diseases with a simple WhatsApp photo. Professor, where do you stand today in respect of this study and its organization through time?
So we wanted to study this study first in Tanzania, because Tanzania there is also a dermatology training center. We have now switched to Madagascar, and we are going to Madagascar to set up the center in 2 weeks. And then we will do the ethical protocol and everything in the local, according to the local regulations, and we expect to start the study in about 6 months to 1 year. It will be a platform study, so we will not just use our own AI, which we have trained on about 5,000 pigment-rich pictures, but we will also allow other machine learning models to be included. There is a model of a Bell AI. There is a model by WHO. So basically, we will always compare these models, and this is perhaps a little bit hard to see in the study phase A to C. We will compare the models to the actual human consultation, which is the gold standard. So basically, trying a stepwise approach to see whether the AI ever reaches the accuracy that the human physician, dermatologist can provide. The disadvantage that we have in dermatology is that, you know, the retina by Professor Paisan, you go in the world, but as you can see, it's very different from machine learning models that are trained on skin. If you do this on pigment poor skin on Europe, typically, it will not translate to a good accuracy in Africa. So we had to retrain machine learning models, and these will be open source. So we will be happy to share all these, including the pictures.
Professeur Navarini, est-ce que vous voyez une...
Professor Navarini, do you see a significant difference between the same type of study that you lead in a country of the north and this type of study in a country, in a southern country?
There are many differences, starting from legal differences, cultural differences. We need to take a lot of time and patience from both sides to really have the study be done by local persons as leaders, as it will be in Madagascar. So we cannot do the study like we would do in Switzerland, but we believe that we can do it on an equally high quality. It just needs a bit of a different approach, and we had to learn a lot about how things are done in these countries, and still are learning, of course.
Et toute dernière question, est-ce que
And a final question, this project that you're developing with Madagascar, is this a project by default because there aren't a sufficient number of dermatologists in Madagascar, therefore they're turning to AI, or to the contrary, could it prefigure the type of medicine that we will soon have in Switzerland, the United States and the UK, where we will use the same techniques that allow us to do the mass detection of diseases?
I think I understood. So whether these can then be translated back to the, perhaps to some extent, but I think we are really doing this because there is a lack of trained human dermatologists in Madagascar and in many countries in Africa. So AI is a potential, has to put these conditions that are very distinct. Actually ever do that. That is the study subject, but it is not quite clear that this will be achieved to 100%, of course.
Merci de cette réponse.
Thank you for this answer. And I would almost want to ask you the same question, Dr. Mathenge. You explained that in Rwanda that you're doing this mass detection thanks to AI because there is a lack of qualified people. But do you think that this is prefiguring medicine of the future?
I think that AI has a really important role in filling those gaps, but we need to be careful because most of the uses of AI now are at the screening level, so at disease detection level. And in medicine, we like to say no survey without service. So one of the worries I'm beginning to have is if we develop all these models for identifying disease, and we don't at the same time strengthen the services for treating those diseases, then the population is going to be disillusioned, because I think it's unfair for me to go to someone and say, you have this, and then I don't do anything about it. And I'm not sure that things are moving at the same speed. So yes, it's helping us fill a big gap, in terms of disease detection. We must not lose the game when it comes to then managing those that we identify.
Une dernière question rapide.
Just a few quick questions. We can see that AI is really disrupting the service that can be offered to the patients, but it's also disrupting the position of the healthcare professionals, because we can see in all of our debates, AI is really cleaving. Some are very for it, and then others are really against it. People are rather in between. And we can see a lot of ophthalmologists and dermatologists who don't want to hear about AI because it also questions their very profession. So what is your reaction with regard to this and your feeling on the matter?
So personally, I've never felt threatened by AI. I think what happens right now is we do so much outside what we should be doing, and what AI is doing is allowing me to do what only I can do, and that will allow me to get better at what only I can do, which is in treating these retinal conditions. But I don't have to be the person who looks for them. Yeah, so that's I think you can only be, people are threatened because they don't know. There's so much about AI we don't know, and then if you don't know, you hear the EU is discussing this and saying it's going to end the world, and you hear AI is going to replace doctors. All you're hearing is all these alarming statements. But if you are participating in its development and understanding that it's coming as a solution, because I think AI also should be developed as a solution, not that it's developed and then we look for the problem that it can solve. If you are involved at that level, then it's not a threat. That's how I see it.
Peggy, même question en quelques...
Peggy, same question for you in just a couple of words. Won't AI be a key revolution for the healthcare professionals, whether they're happy about it or not? It's there, and we will be using it.
Yeah, I mean, I certainly do think AI is going to change how we practice medicine forever. And I speak to this from a lens of both being on the technical side as well as being a physician. I think whether or not people want to hear about AI or not, patients are going to come to you at some point and talk about this, right? And so it's always good to at least understand what's out there. It does seem scary, but anyone who's participating in the active development of AI really gets to kind of see the robustness of which we analyze and test a lot of these models and features. And there's real promise there. We've certainly run some studies where we had patients use AI, we had doctors use AI, and what we saw was that it actually strengthened the patient-doctor conversation, helped patients to be more engaged when they came to their doctor, because now they're informed, they know what they should be talking to their doctor about, and the doctors actually feel like they are more productive and get more out of the interaction. I definitely agree with my colleague here that there are lots of things that doctors have to do that quite honestly are not the best use of doctors' time. And the AI kind of frees up that mental space to really use our skill sets effectively. And I think that more people will realize that over time, as the demand for doctors is certainly not going away, it's only going to increase.
Content ou pas content, on va tous utiliser, on utilise déjà tous.
So we're already using this artificial intelligence on a daily basis, and we will use it increasingly in the future in the field of health. Thank you very much for this very interesting roundtable. I suggest that we take a couple of minutes, because I'm sure there are a lot of questions, comments around what has been said around AI and health application, both in North and the South, because we can see that most of the questions are comment. So for those of you who are looking, following us remotely, I have a lot of questions coming up.
I have a question. It's interestingly, a few years back, when we wanted to even start teledermatology, we are not even talking about AI, but we have, the dermatologists said that we have enough dermatologists in the country, in urban and rural. Why do I need a teledermatology? So do you think we will come to a stage where AI solutions where we have enough specialists or, in both rural areas and urban will want to use this as a solution?
Celle d'entre vous qui veut.
Okay, I can try and say something. I think we need to ask the question to the right people. I'll give an example about a platform called M-Pesa, which is a mobile money platform developed in Kenya, and which I think is the best in the world. Had you asked bankers whether M-Pesa is useful, they would have said absolutely not. Yeah, and nobody asked them. The M-Pesa was developed, the population embraced it. It brought banking to like 90% of the unbanked population in Kenya. It has, World Bank says it has improved the GDP of Kenya by 2%. Nothing else has done that. So I think if you ask me as an ophthalmologist whether something that seems like a competitor to me is good, you'll get the wrong answer. What I think with AI is, as Peggy said, we need to develop good solutions. The users don't care what the dermatologist thinks, don't care what, they will embrace it if it's solving a problem that they have. That's what I think.
D'autres questions, d'autres remarques?
Any other questions, any other comments from the room here?
Allez-y, Alain Labrique, de l'OMS.
So I'm going to say in English, but I think this was, first of all, a fantastic morning session. Really great discussion, really grounded examples from people who have been using AI in the field, and from clinicians who have been at the front lines of this work. I think the one thing that strikes me that we haven't really brought up yet in the conversation is nuance. AI is not new. I just looked up a Lancet paper from 2020, and both in Europe and in the US, over 200 software as a medical devices that use artificial intelligence and machine learning have already been approved and are in use by clinicians, by hospital systems, benefiting patients. So lest we forget that this is not something that just happened last week, it's critical for us to understand the nuance of dynamic AI versus static AI, AI that is trained and then left as a static algorithm that then every input always produces the same output. So I'd love to hear sort of the reaction from our panelists in how nuance comes into this discussion. I'm very cautious about the use of the word fear when we talk about AI, because I think we don't want to play in this forum with academics and intellectuals into the hands of the media frenzy that is trying to sell newspapers. And we really need to talk about this in a dispassionate, empirical way. Thank you.
Merci pour cette contribution, Alain Labrique de l'OMS.
Thank you for this contribution, Alain Labrique from the World Health Organization. Are there any questions or comments from the room?
Madame, alors c'est vite, je vous demanderai à chacun de vous présenter.
I would ask each of you to introduce yourself when you take the floor, so that everybody knows who you are. Hello, and thank you for this morning's presentation. I'm Sophie Deleg. I work in the Kinabad Ijal Hub. I'm a dermatologist. I have a question for...
On a parlé que l'IA...
We said that AI improved diagnosis for diabetic retinopathy. In terms of access to treatment, you mentioned the gap between diagnosis and treatment. How, in practice, can Rwanda... what is the treatment of early treatment of diabetic retinopathy in Rwanda?
Thank you for the question. We have all modalities of treatment for diabetic retinopathy at whatever stage it comes in. I think sometimes we hesitate to introduce technology into African countries because we think that things don't exist. The truth is that excellent practice exists, but usually just in one place. So each country will usually have a center that can provide care that is similar to the rest of the world. And the fear that the clinicians will not be able to manage the condition shouldn't delay the deployment of the AI. It should be support to make sure that they can treat all that. But surprisingly, even in a country like Rwanda, we can treat surgically, we can treat with injections, we can treat with lasers, we have the full spectrum.
Une dernière question, Jai en face.
Merci. This is Jay from Asia eHealth Information Network. I have a question for both the panelists here, Dr. Cikū and Peggy. Dr. Cikū, you mentioned about sharing the retinal images with those who develop the solution. So did you have to follow a certain protocol of anonymizing the information? Because I remember more than 10 years ago, I was associated with a diabetic retinopathy project for one of the colleagues. So we could get the data set from some of the hospitals in India, but there was no regulation, but we had to go through a lot of things before we could actually, of course, the ethics committee clearance and things like that. So did you have to go through this before you supplied? Because it's your own patients, but did you observe, did you get some informed consent or something like that? Did you inform, was there a procedure that was followed before the images were shared? Of course, with the developers. That was the question to you. And then the second question is to Peggy, usually we say, any model is as good as the sample size. So is there a particular metric that says that this is good enough? Is it 500 images, 5,000 images, or 10,000? Is there a particular metric beyond which we can say comfortably, yes, this model works comfortably? Those are the two questions. Thank you.
Peggy en premier, you first.
I guess I can start. Shockingly, no, there's no metric. Surprisingly, what we see is that there are some conditions where you only need a handful of cases for the model to get it right every time, and for us to feel incredibly confident that, wow, the model's just going to know. And that's because if you think about conditions, some conditions are so visually distinct that even you with a human eye and no medical training, you can say, oh, I've seen this. I know what this is. This is what this is, right? And so you can imagine that for those sorts of conditions, the number of cases can be very small. Then there are other cases where they're very nuanced, right? It might be very difficult for even the world's best medical expert to even say, oh, this is what this is. And for those cases, you need thousands and thousands of cases. And so there's no real minimum. The reality is we have to test and learn as we go, and we test each one, and we see, okay, this is where we feel like we can introduce value here. And when we think about introducing value, what we look at is, well, what is the status quo? What is the standard of care today? And can we improve upon that standard of care, right? Because we're not trying to introduce AI in a way that would degrade care. We're trying to introduce AI in a way where we can say, yes, with this, the accuracy improves for everyone by this much.
Mathenge.
Yeah, thank you. And perhaps I could add something to what you say, Peggy. I think with diabetic retinopathy, what we find is that the models are very good at saying, yes, there's disease, no, there's no disease. Then they struggle with the in-between. And in diabetic retinopathy, we want grades of disease. So I think it's exactly what you're saying, that sometimes to say yes and no, it's obvious. But to say at which stage, then you need high sample size. In terms of anonymizing data, yes. So the data set that I have was a study that I did for my PhD, and it's 5,000 images of retinas that are graded at the Moorfields Reading Center. So even to send to Moorfields, I had to anonymize them. So they are anonymized, and the point you raise is quite interesting, because I feel now there's a lot of kind of data mining from Africa, where people are being given cameras and everybody's happy to get a free camera, but nobody asks where this image is going to. And as unfortunately, we don't have any public cloud solutions in Africa, so it also makes it hard for us to work with our own information, so we are always sending them to other people. The problem I've had with my data set is not the anonymity or the ethics around, it's that I give it to people and that's it. I don't know what they use it for. They don't include me in what goes on. Cybersight AI was the first platform that, worked actively with me to improve. And I think that there we need to guard against that. People just taking data and we don't know what they do with it.
Merci à tous les deux, merci à nos 4 invités ce matin.
Thank you very much. Thank you to our 4 guests this morning on this brilliant roundtable on AI. We could spend hours talking with you. And we will continue our reflection on AI with countries of the South with another sharing of concrete experience led by the Doctors Without Borders Foundation.